Yes, perfect. All right, thanks, Roxanne. Can you guys hear me? Kind of, a little bit? Anyone not hear me? Okay, I'll try to project as best I can. I'm kind of the guinea pig with the microphone, I guess. So we'll see how it goes. So like Roxanne said, I am Naomi. I'm one of the pharmacy residents here at SMH. How's everyone doing today? Good? Anyone come for the 90th anniversary celebration earlier? Yeah? Yeah? Okay. All right. So let's get started. Just some quick objectives for today's talk. I wanted to go over identifying risk factors for osteoporosis. What should I look at as a risk factor? That's going to take us into prevention. How can I potentially prevent the best I can? And then we're going to compare and contrast some drug therapies also today. So just some quick facts. 9.9 million Americans have osteoporosis. So obviously, this is an issue for a lot of people. 43.1 million have low bone density. And 1 out of every 2 Caucasian women will experience an osteoporosis-related fracture sometime in her life, which is huge, 50%. This is less common in African Americans. Osteoporosis is less common. And 1 in 5 males will have an elevated fracture risk as well. So this is something that impacts both males and females. It's not just a female-related problem. So what is osteoporosis? Well, essentially, simplifying it, it's really a loss of bone mass. And I have a picture coming up that I think illustrates this really well. And this naturally occurs in people who age. Peak bone mass is generally achieved around age 30, and we kind of just go downhill from there, unfortunately. And additionally, menopause often leads to increases in bone mass. So we see about a 3 to 5% per year decrease in the years following menopause. So that's huge, a huge decline once you hit menopause and going down from that. And the loss of bone tissue leaves a weakened structure. You're going to see a picture coming up that shows that. And this significantly reduces the bone mass that we have. So this is the picture that I was talking about. Obviously, you can see the bone on the right side compared to the bone on the left side. Which one would you rather have? I would rather have this one for sure. So you can definitely tell the difference in the bone mass and why. You can see why your bones are a lot weaker and why we get these fractures with osteoporosis, why this is an issue. I just really like this picture because I think it illustrates this so well. It gives you a visual of what your bones look like and the mass that you're losing. So these are some risk factors. Moving into some risk factors for osteoporosis. Frequent falling, definitely a risk factor. Alcohol abuse, inadequate physical activity, low calcium intake, which we will talk more about that, a lot more about that, smoking, and then additionally vitamin D deficiency, another one. So what are your risk factors for falling? We saw risk factors for osteoporosis. What about for falling? Because that kind of comes with osteoporosis. That's definitely part of why osteoporosis is such an issue, is that it causes falling, it causes hospitalization, causes immobilization, and that's what causes issues. So additionally, risk factors for falling, muscle weakness, which again plays into that physical activity that we talked a little bit about. Selected medications are definitely an issue, and I have a slide coming up to talk a little bit more about some of those medications. There are a lot, so we're just going to broadly cover them. And balance plays an issue in it, and visual deficiency too. So it's important to follow up with your healthcare provider and your eye doctor to make sure you're being properly treated for that as well, because that is a risk factor for falling, which is a big issue. So medications that increase our risk of falling, what are they? Well, generally speaking, it's the ones when you get your pill box. I always say it's the ones that on there say may cause drowsiness and may cause dizziness. Those are going to be the big ones that put you at risk for falling and you want to look out for. So For example, sleepers, zolpidem is a big one. And so definitely if you take Ambien or zolpidem, that is a risk factor. It's a sleeper. It can cause extra drowsiness. Be careful when you're waking up in the morning. If you have some of that drowsiness, just be careful when you're getting up, and talk to your doctor if you're having excessive drowsiness from that. Obviously, it should help you put you to sleep, but if you're getting up in the morning and having extra drowsiness, it's kind of a side effect with that, but you do want to be careful getting up. Cough preparations are another one, and these are over the counter, so it's something important. Everyone takes it. They can cause you also, again, to have extra drowsiness, and you're usually getting up more frequently, having to go to the bathroom potentially. So it's, again, important to be careful when you're getting up with this extra drowsiness. Alpha blockers, these are especially dangerous with the first dose because you can get some what we call hypotension, or your blood pressure can rapidly go down when you stand up. That can cause you to fall. So it's important to have your blood pressure monitored while you're taking these, and just be careful again while you're taking them, while you're getting up slowly, and having your blood pressure monitored while you're on these. We also say that benzodiazepines, this is some drugs like alprazolam, lorazepam, diazepam. All of these can, again, cause you to be very drowsy. Some are more long-acting than others, but it's important if you're starting these or adding additional doses of these that you're watching, being careful that you're not getting too drowsy, that you're being careful when you get up. And then additionally, antidepressants too can cause some drowsiness and are a risk factor for falling. So these are just kind of some broad, basic medications that you can watch out for. And another over-the-counter medication too is Benadryl, actually. I know a lot of people take it, but it can make you really drowsy. I know if I take Benadryl, I'm like falling asleep immediately. So if that does happen to you, you have to be careful. Even with those OTC, you think over the counter it's safe. You still have to be careful with them. They can still cause you to fall, have drowsiness. They do have side effects still. Okay, so what are some prevention measures, moving into prevention from risk? So lifelong participation in weight-bearing and muscle strengthening exercise. Cessation of tobacco use, which there are a lot of cessation programs out there if that's something that you need help with. Identification and treatment of alcoholism. Risk factors for falling, which we talked a little bit about. And adequate intake of calcium and vitamin D, which we will further address as we go on. So exercise. And this is a little bit counterintuitive when you see these definitions. Weight bearing versus muscle strengthening. They're not very intuitive. Weight bearing is when your bones and muscles are working against gravity, and as your feet and legs are bearing the weight. So these are going to be activities like walking, jogging, tai chi, dancing, tennis. They're activities where you are bearing your weight, versus muscle strengthening is going to be building that muscle. So it's activities like weight training, yoga, Pilates, things that you're not bearing your weight on your feet, but you're building muscle separately. Okay, so let's move on to calcium supplementation, another way to hopefully prevent osteoporosis. So it's really important to get adequate calcium and vitamin D. They're both safe and inexpensive ways to reduce the fracture risk. Lifelong adequate calcium intake is needed for peak bone mass and maintenance of bone health. And this is kind of just some trials that have been done, have found a 30% reduction in fractures with an intake of 1,000 milligrams per day of elemental calcium. And we'll talk a little bit more about how much calcium you should be getting per day, how much is recommended. Another study in women who took calcium and vitamin D have found a significant 29% reduction in hip fracture. So again, just the importance of calcium and vitamin D and what those can do for your risk. And actually, adherence is a big barrier. This is something that you will be taking potentially twice a day, sometimes twice a day. And adherence is a huge barrier, but that's where we have to see, if you're not adherent to it, you won't see an effect of it. So if you're not taking it like it's recommended, you will not see an impact from or a benefit from this. And that was kind of found in these trials, is that if people didn't take it, it didn't show a benefit. So it is important to take it. So first up, there's a couple of different calcium supplementations. And the recommended calcium intake it's broken up based on age. So for people who are 50 to 70-year-old males and sex, age and sex is broken up too. So 50 to 70-year-old males, it's 1,000 milligrams per day is the recommended amount of calcium. In males who are 71 years of age or older, it's 1,200 milligrams a day, so a little bit elevated once you get past that 70-year-old stage. And then for women who are older than 51 years old, it is 1,000 milligrams per day. So that's just straight. There isn't anything above that. It's just if you're 51 plus 1,000 milligrams for women. So I think a lot of people struggle with estimating what their daily calcium intake is. And so I thought this table was really helpful. It's not really comprehensive, but it can give you a good idea of the major sources of calcium. We always think milk products, so cheese, milk, yogurt are all going to be really important. And so you can kind of see on here the number of servings a day you eat, so you can put in a number, like 1 or 2. Multiply that by the estimated calcium content, which they kind of give you an estimated. Obviously, in order to really know how much is in something, you'd have to look at the nutrition label that's on there, and it will generally say how much is in there, and then a percent of your daily value also will be listed on that label. And then that will tell you the amount of calcium in milligrams. You would add that up and then add an extra 250 just from non-dairy sources. That's kind of just an estimation of what people would do. And I know personally if I did this, I would not be getting 1,000 milligrams of calcium a day. And I know a lot of people aren't when they add this up. We just don't eat enough to supplement a full amount of calcium in our diet. And that's where calcium supplementations and calcium supplements come into the equation a little bit to help us get our daily value of calcium that we need. So there are a lot of options. I don't know if anyone's gone to the store and looked at calcium supplementations. I'm getting some nods. A lot of different products, right? I went to Target yesterday to take some pictures, and I was just amazed by how many different options we have. There's calcium carbonate, calcium citrate, there's typically calcium by itself, there's calcium plus vitamin D supplements together. They've got chewables, they've got calcium gummies, so pretty much anything you could want, we have. There's a lot of options out there. So everyone should be able to find something that works for them. So we're going to talk a little bit about calcium carbonate. It can be called a lot of different things. There's a lot of different brand names out there, as well as a lot of the generics too. You'll just see calcium, like the picture shows. Just see calcium, but additionally you might see some brand names too. Oscal, Caltrate, Tums even is actually calcium carbonate as well. So there are a lot of different brand names you can see out there and buy, but they're all pretty much the same product, calcium carbonate. And just to some little pearls with calcium carbonate, there is a decrease in absorption if you're taking proton pump inhibitors. So these are things like omeprazole, Nexium. Essentially, these make your stomach more basic, and in order for this drug to be absorbed better, it needs a more acidic stomach for it to be absorbed better. So when taking these drugs, it's actually going to decrease the efficacy and the absorption of calcium carbonate. So that's just kind of something with these if you're on that. And calcium absorption is ensured when ingested with food. So when you're taking calcium carbonate, you should take it with food. Again, it makes your stomach more acidic. It gets the acid going in your stomach eating food. So you need to take food when you're taking this drug. It's best together. You'll get the best absorption from that. This contains 40% elemental calcium. So it's important to note that when you see these calcium supplements, what you see on the bottle might not represent the actual calcium you're getting. So this is only 40% of this is actually elemental calcium. And this is often less expensive than its counterpart, calcium citrate, which we'll talk on the next slide about. So calcium citrate is also citracal. Again, there's different names for it. You can see calcium citrate. It also can come with vitamin D. And unlike calcium carbonate, there is not a drug interaction with proton pump inhibitors. So this may be a better option for you if you're on things like omeprazole and Nexium, like I said before, because this does not have a drug interaction with those. This one, it's best to take it without food because of that absorption. It's kind of opposite of the calcium carbonate, but unfortunately it has less elemental calcium in it. So there's only 21% elemental calcium in it. So generally you have to take about 2 of these for every 1 of the calcium carbonate that you would have to take, because there's just half of the elemental calcium as there is in the calcium carbonate. And generally this can cost a little bit more, about 1.5 to 1.8 times more than calcium carbonate. So I know cost is a concern too, especially if you're buying this on a regular basis. So that's something important to note. I just wanted to highlight also that there are some drug interactions with calcium to be aware of. So common ones are antibiotics, actually. Ciprofloxacin and levofloxacin, and then also doxycycline. And it's important to separate these drugs from calcium if you're taking it. These can interact with the calcium. They bind to calcium and prevent absorption of those antibiotics. And that's the same with the levothyroxine too for thyroid. So it's just important to separate them. We generally say about, if you take it 2 hours before, then it should be fine. And these drugs, like I said, they bind to calcium, and just avoid taking them at the same time. So we're going to move into vitamin D. Why do I need vitamin D? Why is it important? I know we hear a lot about calcium. There's calcium in our bones, but why do I need vitamin D? And so vitamin D deficiency actually causes a decrease in calcium absorption. And this decrease in calcium absorption causes increase in what we call osteoclast production. And osteoclasts essentially take the calcium from your bones and cause it to go into your blood and into your systemic absorption, because when you don't have enough calcium in your blood, where's the source to get calcium from? Your bones. Your bones have a lot of calcium in them, so that's where it's going to take them from. So it's taking calcium out of those bones to give you it in your body. And so this enhances, like I said, mobilization from calcium from the bone. Okay, so what is the recommended amount of vitamin D? It's estimated that about 90% of adults 51 to 70 years old do not get enough vitamin D. Adults age 50 and older are recommended to get 800 to 1,000 units of vitamin D per day. And the chief dietary sources of vitamin D are milk, fortified foods, milk, cereals, and then actually multivitamins generally have vitamin D in it too, and then sunlight, right? We live in Florida, so sunlight is another way to get your vitamin D in for the day. Older patients sometimes are at a higher risk for vitamin D deficiency, They might have malabsorptions, intestinal diseases, renal insufficiency. If you're household bound, don't get out in the sunlight very much. That's another risk factor for decreased vitamin D. And individuals with dark skin also are at a high risk for vitamin D deficiency. Okay, we're going to move on to prescription medications from here. That kind of gives you a good overview of calcium and the vitamin D that you need. And so now we're going to kind of move more into the prescription. We've got prescription medications for both prevention and for treatment. And so first up is going to be the bisphosphonate class. We're going to start with, there's 4 drugs in this class. We're going to start with alendronate, or you might have heard it, the brand name is Fosamax. This drug was FDA approved in 1995, so it's been around for a decently long time, about 10 years. And this is for both prevention and treatment. For prevention, it's 5 milligrams daily or 35 milligrams weekly. And then for treatment, it's 10 milligrams daily and 70 milligrams weekly. So kind of one little pearl with taking this drug is that it needs to be taken in the morning on an empty stomach with 6 to 8 ounces of water. And you need to be sitting or standing upright for at least 30 minutes. And this is really important for a lot of different reasons. The drug can bind to calcium, so that's why you need to take it on an empty stomach. So it can bind to calcium, can bind to other drugs that you're taking, and it will cause it to be ineffective. And then it also causes some esophagitis or inflammation of the esophagus, esophagus ulcers, and even erosion can occur. And that's why it's really important that you are sitting up or standing up for 30 minutes after taking this medication. Because if you lay down, it's going to stay potentially in your esophagus and cause the inflammation or erosion. And then also, it's, like I said, important to take with, not to take it with other medications at the same time, to wait until later for that. I just have a picture of what the label looks like up there too. All right, so the next drug is also a bisphosphonate, and this is ibandronate, also known as Boniva, and this one was approved in 2003, so it's a little bit of a newer drug. It is for treatment, so 100 milligrams monthly tablet, or it can be given 3 milligrams intravenous or IV in a line once every 3 months. So that would generally be done either at some type of an infusion center or at the doctor's office. They can also give it, but that's probably not something that you're going to be doing at home or taking at home. So Boniva, it is also used for prevention, postmenopausal osteoporosis, and this is, again, for the oral medication. It should be taken first thing in the morning, just like the alendronate, with 8 ounces of water. But unlike the alendronate, you need to be sitting up and standing up for at least 60 minutes versus 30 minutes. So it's just a little bit longer of a time frame. So the next bisphosphonate is risdronate, which brand name Actonel or Atelvia, was approved in 1998. It was approved for prevention and treatment. This has a lot of different options. You can take it 5 milligrams daily, 35 milligrams weekly. There's the there's an ER formation of it that you can take. It's delayed release 35 milligrams. There's a 75 milligrams 2 consecutive days every month, and then 150 milligram monthly that you can also take. So there's a lot of different options of this one. Tablets, again, must be taken on an empty stomach. Hopefully you're seeing the pattern. Empty stomach, first thing in the morning, 8 ounces of plain water. They all have an interaction. They all have the esophageal risks associated with them. And this one is 30 minutes, like the alendronate. So it's 30 minutes. And then the last bisphosphonate, zoledronic acid, or reclassed, was FDA approved in 2001. It's also for prevention and treatment. And this one is only available IV, 5 milligrams. So this is one, again, you'd have to go to your doctor's office or to some type of an infusion center to receive this. And they give it over 15 minutes, a 15-minute infusion. But it's once a year for treatment or once every 2 years for prevention. So that's kind of convenient for people. Instead of having to take a pill every day or every week, I can just go into this infusion center for 15 minutes once a year or once every 2 years and get this and be done. But it's important with this one, if you do get it, you need to be pre-medicated with Tylenol and well hydrated prior to going in. And some adverse effects. There's a lot of adverse effects with this one. Headache, fever, muscle pain occur about 32% of the time, which is actually a lot. About a third of the time you have one of these. But after the first dose, that does go down over time. So decreases to about 7%, 3% for the third dose. So even though you will more than likely have a reaction, some type of adverse reaction the first time, it decreases as you go. And so the general mechanism of these drugs is to inhibit the osteoclast-mediated bone resorption. So like we said, the osteoclasts are taking calcium from your bones to your systemic system. So these are inhibiting that from happening. And it's important with all of these drugs. When they did all of the trials, people had been taking about 1,000 milligrams of calcium and 400 units of vitamin D. So they've already been supplemented with calcium and vitamin D before these drugs. And that's important to note that you have to be doing the calcium and vitamin D to show these benefits from these drugs. So even if you are taking something prescription, it's still important to be taking that calcium and vitamin D on top of that. And the difference with this, with some of the other bisphosphonates, is that it's thought to localize and preferentially go to sites of high bone turnover. So that's why this one is so long acting with the 1 year. Once every 2 years is because it's thought to localize to those bone areas with high turnover. So just for the bisphosphonate class in general, the optimal duration use for the treatment of osteoporosis has not been determined. It's important, your doctor will probably evaluate therapy periodically, and low risk of fracture should be evaluated. If you're at a low risk, it should be re-evaluated every 3 to 5 years. The reason for this is that studies haven't really shown that taking this drug long term has any more benefit than stopping it after 5 years. So we still have to study that in the future. That's the point that we need to study, and it's kind of, do the risks outweigh the benefits for this drug, because we have seen some osteonecrosis of the jaw that's been reported when we extend therapy greater than 5 years. And also some low trauma atypical femur fractures have reported when we've seen use for over 5 years. So that's kind of, if we don't have a clear benefit, we're kind of weighing, is this better to continue, or can we stop it and avoid some of these potentially harmful side effects that can occur with these drugs? So some oral adverse effects of this class generally, you're going to see diarrhea, indigestion, abdominal pain, so just general GI side effects that are kind of uncomfortable, but overall not too bad. Alendronate and risdronate can also cause influenza-like symptoms as well, so it can kind of just make you feel a little bit malaise. So that's another thing to watch out for with those, but generally not a bad class, and I think it's something that a lot of people I know I've seen have been on alendronate and tolerated it pretty well. Okay, so we're gonna go, I just stuck in kind of a general table to help you compare them a little bit, just to compare the differences between these drugs. So you can kind of see the difference in the date of approval. They generally occurred, though, between 1995 and 2003. They actually are all generic. Their patents are all up, and you can get these generically. That does not necessarily mean that they are cheap, but they are available generically. And then you can kind of see the differences between which ones are available as a tablet, which ones are available intravenously, and then again, the frequency differences between those. There are slight frequency differences between them. The daily and weekly for Lendronate versus a Bandronate monthly or every 3 months if you get the IV injection, and the Risronate daily, weekly, or monthly, and then zoledronic acid once yearly, which I know is a big benefit for people like that a lot. So we're going to move on to calcitonin. Also, another name for it is Fortical. It was approved in 1975, so it's been around for a while. This is for women who are at least 5 years postmenopausal. It reduces vertebral fractures, but has not been shown to reduce non-vertebral fractures. So that's kind of a little hesitancy for us to use it. So it's kind of one that we don't see very often, and it's maybe if you don't tolerate any of the other drugs, this maybe could be an option. And you can give it 200 units single dose intranasal spray. And then the injectable is a 0.5 ml injection intramuscularly. Something to note with this is if you are allergic to salmon, you will probably have a reaction to this drug. So it's important to avoid if you're allergic to salmon. And then here are just kind of some of the common adverse effects of these drugs. So the injectable, you're going to see more nausea, injection site reaction. So that can be redness, swelling, some pain there. And then you can get flushing of the face and hands with the injection. With the intranasal, you're going to get more of the local with the nasal, having a runny nose, a bloody nose, and then allergic reaction actually is potentially for both. So next we've got the selective estrogen receptor modulators, and this is actually Evista, or Viloxifene is the generic name of it. This is also available generically. It was approved in 1997 and is approved for prevention and treatment of osteoporosis in postmenopausal women. And it's a 60 milligram tablet daily. And this drug is, how it works is it's mediated through the binding of estrogen receptors. It activates estrogen pathways in some tissues and blocks it in others. So it activates estrogen in the bone, and this decreases bone resorption. So it decreases bone resorption and turnover, and it increases bone mineral density and decreases your fracture risk. So that's how this one works. It also additionally has shown a reduction in risk of invasive breast cancer in postmenopausal women with osteoporosis. So it's used a lot in those patients who are at a high risk for breast cancer and have osteoporosis. For example, someone who has a family history of breast cancer is one example of someone who it might be used in. And it also increases some side effects. It increases the risk of clotting in women, especially with a past history of clotting. So often we'll avoid it. If you've had a history or active clotting events, we'll generally avoid this one. And it did also show an increased risk of death due to stroke in women with coronary heart disease. So in general, not the best really option for people who have heart disease or a history or active clotting. Some adverse events from this is hot flash, leg cramps, and I already mentioned the clotting, all potential adverse effects from this medication. So the next is estrogen and hormone therapy replacement. And I'm not going to dive too much into this because we could spend an hour alone talking about hormone replacement therapy. It's just, there's so many options and it's such a huge topic. So we're just going to kind of do a wide view of it just quickly. So there, like I said, there's a wide variety. There's oral options, there's transdermal preparations. You're going to see estrogen, progesterone only, and then also combination products of the two of those. It's important to note that if and when treatment is stopped, bone loss can be rapid. So generally, if it's stopped, they'll put you on something else pretty immediately after that. And I think it's important to note the safety facts for this. The Women's Health Initiative study reported increased risk of heart attack, stroke, breast cancer, and clotting during 5 years of treatment. So generally, this isn't estrogen and hormone therapy is not going to be used just for osteoporosis. It's generally used in women who are having some side effects with menopause, and then this is kind of an added benefit of that therapy. So it's generally not prescribed just for the use of osteoporosis alone. Our next drug is Forteo. It was approved in 2002. This actually increases bone formulation. It is for treatment of osteoporosis in postmenopausal men and women, well, postmenopausal women and also in men at high risk for fractures. And this is a daily injection, which I know, oh yeah, yes, no problem. Sorry about that. So this is the daily injection, which I know can be painful, and a lot of people are not really fond of giving themselves a daily injection. Those of you who have been on insulin or are on insulin probably know that it is not very much fun. This is really used after other therapies have been used. This isn't generally the primary therapy that is going to be used first line. And this is delivered, you can kind of see the pen up there. It is delivered as a pen. That pen contains 28 daily doses of 20 micrograms. And you're going to inject this into the intra-abdominal wall, so abdomen, or the thigh is where this is injected. And adverse events for this, pain, nausea, and then injection site reactions are common also. Again, redness, swelling, pain when you inject it. So this works by binding to receptors that have affinity for on the bones and the kidneys. So it's preferentially stimulating the osteoblasts, which help with bone calcium growth, versus the osteoclasts, which are going to take away calcium from the bone. So this is going to build your bone calcium by increasing those osteoblasts and increase your bone strength through building your bone with calcium. But generally, again, just not used first line. It's usually used after other therapies. And it's an expensive option because you do have to buy this pen. So if you don't have great insurance, even if you do, it's probably going to be pretty expensive. Yeah. And then our next drug is going to be Prolia. So Prolia was FDA approved in 2010. So this one is brand name, which is important to note. It's also fairly expensive. It's for treatment of osteoporosis in postmenopausal women at high risk of fractures. And this needs to be administered by a healthcare professional every 6 months. So this is when you'll have to go into your doctor's office to get it. You won't pick it up from the pharmacy. You'll probably go to your doctor's office to receive it. It is a single-use, either prefilled syringe generally, that contains 60 milligrams in 1 ml. They're going to inject that subcutaneously either into your upper arm or upper thigh, or again, the abdomen too could be an injection site for this one. And Prolia also works by decreasing the osteoclast formation, function, and survival. So again, those things that are taking away calcium from your bone and putting them into your body, we're decreasing that. This is going to help increase bone mass and increase strength of the bone. And adverse events with this is decreased calcium, just because, again, we're decreasing it, taking it from your bone to your body. But hopefully you're getting calcium supplementation to help with that. Skin infections is another one. And then skin reactions also can occur with this because, again, it's an injectable. So it can irritate your skin by injecting it. And this, too, can cause, like the bisphosphonates, it's also been shown to cause osteonecrosis of the jaw and femoral fractures. But then additionally has the risk of serious infections, too. All right, so to conclude, there are ways you can reduce your risk of osteoporosis. We've got exercise is a big one, and then calcium and vitamin D are really important. Supplementing that, I know I don't get enough in my diet, so it's really important to add that supplementation on top of what you're eating. And then just to review, calcium citrate versus calcium carbonate. There are differences with when to take it, whether to take it with food in the case of calcium carbonate or not with calcium citrate, and then there's differences of absorption because of that. And then calcium citrate is only 20%, about 20% of elemental calcium versus calcium carbonate being about 40% of elemental calcium. And then prescription therapy, there are a lot of options that we've gone over, and that's something that you can talk to your prescriber about. Hopefully you got some of the pros and cons of them, which ones are available generically. Prolia is not. So what questions do you have for me? Yeah. The fracture risk assessment. On your sheet. I honestly don't know a bunch about that. Yeah, I have it. Yeah. No. I've heard it's a frax test. I think they can do it at your doctor's office. As a pharmacist, I really haven't been involved with that, but there is a frax test that they can do there. Yeah. Abbreviated FRAX, frax test. Okay. Okay. I think, have you been on? Yeah. I mean, they're right as far as I'm assuming you're on some type of bisphosphonate probably prior. Alendronate. Yeah, no, that's great. Honestly, I don't really have a solid opinion on it. The unfortunate thing about a lot of these drugs is that we haven't done long-term risk-benefit studies. So we don't really know the long-term benefits. What is an ideal amount of time to be on it? We don't really know that because we haven't had solid evidence that says X many years is how long you need to be on this for it to be beneficial or for it not to be beneficial, for us to stop seeing benefits of this drug. So I think it's something that you have to weigh with your doctor. Am I getting more benefit from this, or am I starting to see, you know, maybe some side effects, maybe some potential, you know, am I seeing some risks that I don't want to see with it? And then it's probably time to stop it. But yeah, unfortunately, we don't really have evidence that points us towards this is an ideal amount of time to be on something. I wish we did, because it would help. Yeah, it would help us out as pharmacists to have that, but we don't have that evidence right now. Yeah. Yeah, I honestly haven't heard a lot about that recently. I took a lot of this information from the Osteoporosis Foundation guidelines, and so this is what they are recommending based on evidence, a lot of studies that have been done that have shown a benefit. And so that's kind of where I stand, I guess, right now, is where that's the evidence that I've seen. So for now, I think continuing to take calcium, it's important. As with everything, if you get too much of something, there are risks with it, and you do not want to get too much of it, but we want to make sure that we do have adequate amounts of it. Yes. Yeah, it is, and it kind of just depends, again, on if you're on something like a proton pump inhibitor, like omeprazole, something like that, you might not want to take it, but yeah, it's, yeah. No. And then take calcium carbonate. Okay. Well, it does make your stomach more basic. So any type of drug or supplement that is basic also is not going to be absorbed as well. So that's okay. You can take it 3 hours after, but yeah, essentially that's why. If you're taking omeprazole, it's best to take calcium citrate with it.
Supplementation themselves, and one of the risk versus benefits that you have to weigh is kind of as you get older, your kidney function goes down. So it's important staying really well hydrated, because one of the things that came out of those studies was actually an increase with renal stones or kidney stones. So different people are kind of predisposed to that anyway, so it's kind of the discussion with your physician of saying yes, no, you know, you kind of have a predisposition to this. The other thing, a lot of the things that Naomi has talked about today are medications specifically treating osteoporosis, that you really kind of need that calcium in order to build the bones and that sort of thing. So you're using drugs in combination. Those studies were really just looking at calcium supplementation. So if I'm a woman over 50 years old, should I be taking calcium and vitamin D just kind of together by themselves, not really with anything else? So you kind of have to look at your risk versus benefit. So if you're at a very high risk for osteoporosis, calcium supplementation, in addition to something like this, or just calcium supplementation overall, might be a benefit to you. So you kind of have to look at the population of the studies when they were doing that, and really kind of take your factors into account of looking at that. But yeah, you are right. It's been in news a lot. And the only reason I know is because my mom, of course, called me and asked me all about it. So. Yes.
Yes. Yes, all of those. When they do these clinical trials, they are assuming people are given calcium and vitamin D supplementations on top of those drugs. So generally it's 1,000 milligrams of calcium and 400 units of vitamin D. But yeah, they are supplemented with calcium and vitamin D before these trials are done to show benefits with these drugs. So it's assumed that you are getting those supplements. Yeah, they can, definitely. Yeah, again, it's that acidic versus basic type of a thing, and that depending on if your stomach is acidic versus basic, that impacts the absorption of these drugs sometimes. So that's the case, yeah. No, it won't. It won't irritate it. Your stomach is so basic that a lot of these drugs are so acidic when you do have that acid coming that a lot of these drugs aren't even going to be that acidic. I mean, your stomach runs at, I think, a pH of about 2. It's very, very acidic. So, no, it won't irritate it. Yeah, Forteo you should definitely only take for 2 years. Like I said, the other ones we don't really have solid evidence pointing to the ideal amount of time where it is beneficial versus where we lose those benefits. Like for example, the bisphosphonates, like I said, there have been studies showing that after 5 years it stayed in your system, and we really haven't seen additional benefits beyond that. So that's really the only one that they have solid evidence of 2 years. Yeah, it can have an impact for less than 2 years. It's just not recommended that you continue taking it for over 2 years. Not that I'm aware of. Yeah. Problem. That I'm not sure of. Again, I think they could probably do that at your doctor's office. All right, well, thank you guys. Have been a really great audience.
Thank you so much, Naomi. We learned so much today. And I wanted to let you all know that our next talk is on Thursday. It's about obesity and healthcare risks. But the next pharmacy talk we're going to have is next week on Tuesday, November 10th, and that's going to be drug interactions. So that should be a really interesting talk as well. So we want to give a big thank you to the pharmacy team because they're giving their time to come down here and give this talk to the community. So thank you so much.